Imagine a world where breast cancer can be stopped before it even starts. With today's advancements in preventive medicine, this vision is increasingly attainable. However, despite these developments, a significant portion of the population remains unaware of available preventive medications. One of the most pervasive misconceptions is that these interventions are exclusively beneficial for those with a family history of breast cancer. In reality, preventive treatments can greatly benefit individuals across a broader spectrum of risk. Breast cancer is highly prevalent, with approximately 1 in 8 women in the United States being diagnosed at some point during their lifetime. While early detection remains a cornerstone in reducing breast cancer mortality, prevention through prophylactic surgery or medication has emerged as an equally critical strategy. Prophylactic surgery, such as preventive mastectomy, significantly reduces breast cancer risk in women with a very high genetic predisposition, such as carriers of BRCA gene mutations. For these individuals, surgery can offer substantial protection by removing breast tissue before cancer can develop. Medications also play a crucial role in prevention for women identified as high risk through a comprehensive risk assessment. Risk determination often incorporates genetic factors, personal and family medical histories, reproductive history, and other clinical parameters. Prevention seeks not merely to detect cancer early, but also to prevent it completely. And this can affect the lives of many women worldwide. Selective estrogen receptor modulators are some of the most common medications used for cancer prevention. The NSABP P1 trial randomized approximately 13,000 women identified as high risk through risk assessment models or a history of LCIS, lobular carcinoma in situ, and these were randomized to either tamoxifen or placebo daily for 5 years. Results showed that tamoxifen significantly reduced the risk of invasive breast cancer by approximately 50%. Importantly, side effects such as thromboembolic events and endometrial cancer were observed in women older than 50 for tamoxifen compared to placebo. So selecting patients carefully is very important. A second study called the NSABP P2 study or STAR trial compared Raloxifene, which had been approved for osteoporosis, with tamoxifen. And this trial found Raloxifene to have fewer side effects compared to tamoxifen, but overall the efficacy was not as good as tamoxifen preventing breast cancer. These findings emphasize the importance of individualized treatment based on risk profiles and patient preferences. Another class, aromatase inhibitors or AIs, such as Anastrozole and Exemestane, is increasingly recommended through not specifically FDA approved for preventive purposes. These medications significantly reduce estrogen production by inhibiting the enzyme aromatase, thereby decreasing the risk of estrogen receptor positive breast cancer in postmenopausal women. Their preventive efficacy has been demonstrated in clinical trials despite concerns over side effects like musculoskeletal discomfort and bone loss. One pivotal trial, the IBIS-2 study, done in the UK, randomized approximately 3,800 postmenopausal women at high risk for breast cancer to either anastrozole or placebo for 5 years. Anastrozole reduced breast cancer risk by 53%, supporting its use as a chemopreventive agent. Management of side effects such as joint pain and decreased bone density is important to maximize patient adherence and outcomes. The MAP3 trial was a randomized placebo-controlled trial that enrolled approximately 4,500 postmenopausal women identified as high risk for breast cancer based on age, family history, or prior benign breast disease. And these women were randomized to receive either Exemestane or a placebo daily for 5 years. The trial demonstrated a remarkable 65% reduction in invasive breast cancer incidence among those treated with Exemestane. This significant finding reinforced the credibility of aromatase inhibitors or AIs for preventive use, leading to their inclusion in clinical guidelines. However, potential side effects, particularly musculoskeletal symptoms and bone density loss, warrant careful consideration when evaluating this preventive strategy. In alignment with these research insights, national guidelines have progressively adopted personalized approaches. The American Society of Clinical Oncology, or ASCO, now actively recommends SERMs and AIs, tailoring recommendations according to menopausal status and individual risk assessments. Similarly, the National Comprehensive Cancer Network, or NCCN, emphasizes detailed personal and clinical history in decision-making processes, recognizing the diversity of risk profiles among women. Risk assessment tools such as the Gail model or the Tyrer-Cuzick models are invaluable for estimating breast cancer risk. They consider factors like age, reproductive history, lifestyle, and previous medical conditions to facilitate informed decisions regarding preventive medications. Nevertheless, these models are aids rather than definitive predictors, and clinical judgment remains paramount in decision-making. Despite the availability and effectiveness of preventive medications, though, uptake remains relatively low, largely due to fears of adverse side effects. Recently, a study from Italy provided encouraging evidence supporting the efficacy of low-dose tamoxifen for women at high risk of invasive breast cancer. This trial included patients with precancerous lesions like lobular carcinoma in situ, LCIS, as well as ductal carcinoma in situ, DCIS, which is stage 0 breast cancer. Patients received a low dose of tamoxifen of 5 mg daily, and that reduced the incidence of breast cancer compared to placebo. In the United States, a 10 mg dose formulation is available and can be considered for patients who find the standard 20 mg dose intolerable. Addressing these concerns through tailored dosing options alongside comprehensive and accessible education is key to encouraging more women to adopt preventive measures if they need it. Looking forward, ongoing research holds promise for even more refined and individualized preventive strategies. Genetic profiling and precision medicine may soon enable highly tailored preventive treatments, reducing risk further and minimizing side effects. This represents a significant step towards proactive, personalized prevention rather than reactionary treatments after diagnosis. In conclusion, medications like Tamoxifen, Raloxifene, Exemestane, and Anastrozole represent powerful tools in breast cancer prevention, with demonstrated significant risk reductions. As clinical guidelines continue to evolve towards personalized medicine, preventive strategies will become increasingly tailored and accessible, potentially transforming women's health globally. If this conversation sparks your curiosity about preventive medications, we encourage discussing these options with your healthcare provider.